Welcome to the Explainer. Okay, today we are going to completely demystify some of the absolute most complex renal mechanisms in the human body. Instead of just memorizing a dry list of symptoms, we're actually going to trace every single clinical finding right back to a specific failed regulatory function. It's like a giant puzzle, and by the time we're done, you'll understand exactly how structural kidney failure and these highly specific water balance receptor defects can profoundly impact the entire body.
Okay, let's dive right into this. Here is our roadmap. First up, chronic kidney disease and its domino effect of complications. Then, we'll compare dialysis methods, and finally, we'll pivot to a fascinating hormone disorder, nephrogenic diabetes insipidus.
Part 1. Chronic kidney disease and the irreversible shift.
Our kidneys are incredibly resilient. They can actually maintain totally normal fluid chemistry until more than 50% of their functional capacity is just gone. But once we cross that threshold, chronic kidney disease begins. And the absolutely crucial word to remember here is irreversible. Unlike acute kidney injuries, which come on suddenly and are potentially reversible, CKD is a progressive, permanent loss of nephrons. Over months or years, this slow deterioration produces a massive biochemical disturbance that eventually culminates in uremia, which is where waste products just dangerously build up in the blood.
Moving right along to Part 2, the domino effect of CKD mechanisms. So, when you think of kidney failure, you're probably picturing fluid overload or poor urine output, right? But I want you to consider this for a second. Why in the world does kidney disease cause severe anemia and stunted growth? What are the actual biochemical pathways that break down in CKD patients to trigger these seemingly completely unrelated issues?
Now, what's really interesting here is the direct link between your kidneys and your blood. Healthy kidneys do so much more than just filter urine. They actually pump out a vital hormone called erythropoietin. Think of this hormone as a chemical messenger that literally tells your bone marrow, hey, we need more red blood cells.
So, let's trace exactly what happens when that system breaks down. Step 1. The kidneys fail. Step 2. Because that renal tissue is damaged, the production of erythropoietin severely drops off. Step 3. Without that vital hormonal signal, your body's red blood cell production essentially just grinds to a halt. And finally, Step 4. The patient develops severe anemia, which leads to that pale skin and profound fatigue we see so often in CKD. Because this is a hormone deficit at its core, the medical treatment here relies on giving recombinant human erythropoietin to basically manually stimulate that red blood cell production.
Now, what about stunted growth in pediatric CKD patients? It is a huge misconception that this growth delay is simply because they have a poor appetite. No way! It is actually a deep, systemic biochemical failure. CKD causes profound disturbances in calcium, phosphorus, and vitamin D metabolism. And that whole mess is compounded by metabolic acidosis. Because the kidneys just can't regulate these minerals anymore, the patient develops chronic hypocalcemia, meaning super low calcium in the blood. So to survive and support parathyroid function, the body is literally forced to rob calcium from its own bones just to keep the bloodstream supplied. This progressive weakening of the bones is called renal osteodystrophy. That's exactly why treating this requires specialized mineral management and recombinant growth hormone, not just extra calories. If we don't catch and manage this early, the child faces permanent skeletal deformities and fractures.
Let's look at Part 3, comparing dialysis methods.
When a patient reaches end-stage renal disease, we have to step in and medically replace these failing regulatory functions. Dialysis is basically how we mechanically manage fluid, electrolytes, and waste when the kidneys just no longer can. And the two primary methods are very different mechanically. In hemodialysis, blood is actively pulled out of the body through a vascular access point, run through an external machine where a special filter and dialysate fluids scrub out the waste, and then the clean blood is returned. Peritoneal dialysis, on the other hand, skips the external blood filter entirely. Instead, dialysate fluid is pumped directly into the patient's abdomen, the peritoneal cavity. It actually uses the body's own natural peritoneal membrane as the filter to pull waste and fluid across.
But this brings us to an absolutely critical safety alert. Because peritoneal dialysis involves putting fluid straight into the abdominal cavity, infection is a massive risk. If a patient or caregiver is draining the dialysate and it looks cloudy at all, that is an absolute medical emergency. Cloudy fluid is the classic hallmark sign of peritonitis, a severe internal infection, and it has to be reported to a healthcare provider literally right that second.
Which brings us to our final section, nephrogenic diabetes insipidus.
We're going to pivot a bit here.
shifting away from structural kidney failure to look at a highly specific, microscopic water balance defect. Diabetes insipidus is a disorder of water balance. Normally, a hormone called antidiuretic hormone, or ADH, tells your kidneys to hold on to water. But in nephrogenic diabetes insipidus, or NDI, the body's making plenty of ADH, but the kidneys, they completely fail to respond to it. As a result, the classic clinical picture of this condition is the constant excretion of massive volumes of completely dilute urine, along with this intense, unquenchable thirst.
And this brilliantly illustrates just how severe the condition is. Think of what we call the desert scenario. Imagine a totally healthy person stranded in a desert with no water. Their body senses that intense physiological stress, pumps out massive amounts of ADH, and the kidneys maximally retain every drop of water to keep the person alive. Now imagine a person with NDI in that exact same desert. Their brain sounds the ADH alarm, but the kidneys are completely deaf to it. They just keep urinating massive amounts of free water despite the extreme stress. The result is rapid, life-threatening dehydration and hypernatremia, meaning their blood sodium becomes dangerously concentrated simply because they are losing so much pure water.
To really wrap our heads around this, we have to contrast it with central diabetes insipidus. In central DI, the core problem is hormone supply. The hypothalamus or pituitary gland in the brain basically fails to make or release ADH, so the blood levels of the hormone are low or totally absent. But in nephrogenic DI, it is strictly a receptor problem down in the kidneys. The brain is working perfectly fine, the ADH levels are normal, maybe even elevated, but those renal receptors are totally unresponsive to the chemical signal. The message is being sent, but nobody's picking up the phone.
And that distinction gives us our biggest treatment takeaway for today. Desmopressin is a synthetic replacement for ADH. If a patient has central DI, that supply problem we just talked about, desmopressin works beautifully to replace what's missing. But if you give desmopressin to a patient with nephrogenic DI, it will completely fail. Why? Because you are just throwing more hormone at a kidney that is already completely deaf to the signal. Management for NDI has to rely on strict hydration and specialized endocrinology protocols for sure, not just simple hormone replacement.
Which leaves us with this final thought. Whether we are looking at the irreversible structural loss of nephrons in chronic kidney disease or a microscopic receptor glitch in nephrogenic diabetes insipidus, we can really see just how fragile and deeply interconnected our body's regulatory systems truly are. When our body's ultimate regulators stop listening to chemical signals, how can we continue to innovate to restore that balance? Thank you so much for joining me for this explainer, and keep asking those deep questions.